Dr. Adam Levine, welcome to News First, and thank you for joining us.
Thank you. It's wonderful to be here.
You are a medical practitioner, physician who's had plenty of experience on the field, as well as in doing research into epidemics. You've been in sub-Saharan Africa. You've worked with pandemics like the Ebola virus, for instance. Where are we right now? I think the burning question on everyone's mind, Dr. Levine, is where are we right now? Are we at the start of this thing? Are we in the middle? Or is there a light at the end of the tunnel?
I think probably the best way to describe it is that we are coming to the end of the beginning. And the beginning is the scariest phase of any pandemic and of any process in life. We've seen the rapid rise in cases, first in China and East Asia, and then spreading to Europe and North America, and now spreading to basically every country in the world. We've seen the rapid dash as countries put into place social distancing measures of various sorts, and as they prepare their health systems for the pandemic. And now we're moving into a new phase where we learn to figure out how we live as a planet with this virus and with this pandemic, which is going to be with us for certainly for some time to come, for years at least, and possibly for the rest of our lives. So we have to figure out how we adjust daily life, how we adjust our economies, how we adjust our systems, and most importantly, how we adjust our public health and healthcare systems to be able to manage this disease as we have managed many other diseases throughout history.
You and your team of doctors were recognized even by Time magazine as one of the 100 people of the year for your work in sub-Saharan Africa during the Ebola outbreaks. How does that compare to what you're seeing right now?
Yeah, I mean, it was certainly a great honor to be named as Person of the Year, as one of many, many Ebola fighters in West Africa and around the world in 2014 during the Ebola epidemic there. And I think we learned some really important lessons from the Ebola epidemic that can be applied to COVID-19, though it's also true that this pandemic is, different in many ways than the Ebola epidemic in West Africa. Ebola was far more deadly than COVID-19. The mortality rate was about 50% for Ebola as compared to about 1% for COVID-19. But COVID-19 is actually more contagious than Ebola. It's more easily spread from person to person, which makes it harder to get under control from a public health standpoint. But I think one of the important lessons that we did learn during the Ebola epidemic in West Africa is just how rapidly a new disease or an emerging infectious disease can shut down a healthcare system, can shut down an economy. When I arrived in West Africa in 2014, there were no functioning hospitals or clinics anywhere in the country because doctors and nurses and other healthcare workers were afraid to come to work because they didn't have sufficient protection. And that meant that at the end of the day, when we counted all the deaths, probably 10 times as many people died from other diseases during the Ebola epidemic in West Africa than Ebola itself because of the shutdown of the healthcare system and the public health system. They stopped doing vaccinations, for instance, for measles and many other infectious diseases that led to many more deaths than we saw from Ebola itself. And we are seeing that now in the United States, and we're seeing that now in Europe, and we're seeing it everywhere in the world. The impact that this pandemic is having on our healthcare systems means that many more people are dying of other diseases because of the COVID-19 pandemic than are dying of COVID-19 itself. And so this is an important point. And what it means is we have to strengthen our healthcare systems. We have to ensure that all of our healthcare workers have sufficient supplies of personal protective equipment, the masks and the gowns and the face shields that they need. Also, the training and the systems in place to protect them so that they know how to protect themselves from getting infected. Without that, they're not going to be able to safely perform their job, and they're not going to be able to treat people for COVID-19 or for any other disease. And so that's got to be, step one in terms of ensuring that we can manage this disease and live with it.
So you've spoken about four pillars in dealing with this outbreak. Could you talk us through that?
Yeah, so these are not anything that I've made up. These are the standard measures that have been used for decades to control every infectious disease outbreak, not just Ebola, not just COVID-19, but we've used them for decades because they work. And I think one of the missed opportunities that countries had was to institute these four pillars early on during the COVID-19 pandemic. And those countries that did actually have not seen the high numbers of cases that countries that didn't have seen. So the four pillars are very simple. Number one is community education and public health messaging. This is all about teaching people what the disease is, what the signs are, how to identify if you might have it, what to do if you might have it, and also how to protect yourself. Things like hand washing, things like social distancing, things like good hygiene and cleaning in your home. All of these messages help reduce the burden of disease in the population by slowing the spread of the disease. And they also help people feel less afraid because they know about the disease and they know what to do. And so it reduces panic. Number two is surveillance. We need to be able to identify every single person who is infected with the disease. And the only way to do this is through really excellent contact tracing. Whenever somebody is infected, you identify everybody that they've been in contact with, you quarantine those individuals, and you follow them for the incubation period, which for COVID-19 is about 2 weeks, and see if they develop symptoms. If they do, you test them immediately and then isolate them if they are indeed infected.
I'm just going to jump in for just a quick moment, but when it comes to contact tracing, at a certain point, it just becomes superfluous, is it not? I mean, it's counterproductive almost. For instance, in a community spread situation, does it still make sense to contact trace?
Absolutely. It's never superfluous. It's, in fact, the only way to control the epidemic. All of the measures that you're seeing around the world, these huge lockdowns, they are not the standard treatment for an epidemic. They are what we're doing because we failed to do the four pillars adequately. And when the four pillars are done adequately, it allows you to actually control the pandemic while still operating your economy and preventing people from going hungry and all of the things that we're seeing around the world because of these massive lockdowns. Contact tracing allows you to identify everyone who's sick, to separate them out from the population, to identify everyone who might potentially become sick, i.e. their contacts, and separate them out from the population. And once you've done that, you've stopped the spread of the disease in your society. But to do contact tracing, you need pillar number 3, which is laboratory testing. And that's been one of the biggest failures around the world. Without laboratory testing, you can't know who's infected, and therefore you can't adequately identify who they are, separate them, and identify their contacts. And so you need to have really good and high quality testing that's available to every single person who might be infected, every person with potential symptoms of the disease.
So what are the tests that are available right now? We've heard of so many. There's antibody tests, PCR tests. So shed some light on all of this.
So the standard test for diagnosing COVID-19 is a PCR-based test, a polymerase chain reaction test. And there are many different companies that have developed assays to test for the disease. Usually it involves either a nasal swab that's inserted in the nose or a throat swab, and then a little bit of virus gets on that swab. It's put into this machine, and the machine amplifies that virus to the point where we can detect it. And that's the standard for diagnosing the disease right now in individuals. There are other types of tests you may have heard about, such as the antibody tests. Those are tests to tell you whether you were infected with the disease in the past, but aren't good for diagnosing the disease if you're currently infected with it. Those may serve a different purpose later on. But for right now, the only test that really can tell you definitively if you are infected is the PCR test. It's not perfect, but it's pretty good, and therefore worth using at a large level. And then finally, the fourth pillar is treatment, isolation, and care. So the worst thing you can do in any pandemic and any new emerging infectious disease is tell people that it's real, tell people that it's deadly, and then say, by the way, we have nothing to treat you with if you get infected. Because then why would people want to come forward and get tested if they don't think there's any treatment for it? So you have to have good measures in place to provide treatment for those who are sick. And in the case of COVID-19, that means having enough hospital beds, having enough oxygen, and having enough ventilators for those who get really, really sick so that you can provide good care for them and help them hopefully survive the disease. But at the very least, show that there is a possibility for treatment, that there is a possibility for cure, and that people need to be able to come forward and get tested so that they have the opportunity to access that care. That's how we controlled it with Ebola in West Africa. That's how we controlled smallpox. That's how we controlled measles. That's how we control every major infectious disease.
So if you don't have one of those going, you're in trouble.
Absolutely. Everyone likes to argue about which of these four pillars is the most important, but I say that that's like arguing which of the four legs on your chair is the most important leg. Without all four of them in place, the whole system collapses. And that's largely what we saw. The lack of testing in the United States, for instance, and in certain parts of Europe, caused the entire chair to collapse. And when the chair collapsed, the only thing that we could do was strict lockdowns to absolutely prevent every human from interacting with every other human in society. This, as we have seen, has devastated economies, has caused people in some parts of the world to go hungry, caused many people to lose their jobs. And it's not the way that we're supposed to run a pandemic response. It's the way that we've had to run it because of a failure of one or more of the four pillars of pandemic response.
Okay, so I'm going to ask you a question as a doctor. How severe is this disease?
So on a range of severity, it's more severe than the common influenza that we see every year around the world. It is less severe than Ebola. It's less severe than many other diseases that we see and deal with. In many places of the world, people are familiar with diseases like malaria, like dengue. And I would say that COVID-19 is less severe than these diseases, less severe than cholera, for instance, which is a disease that I spend a lot of time treating. So, on the spectrum of diseases, it's not the worst in the world, but it certainly is significant. It certainly has a mortality rate of probably around 1%, which is, quite high compared to normal types of respiratory infections that we might see every year.
Okay, but we've both heard of the counter argument to that the mortality rate that was predicted about, let's say, a month ago, and the evidence-based research that is coming out now, there's a contrast between the two. The mortality rate doesn't seem to be as bad as it was predicted by the WHO, and for instance, by the report published by Imperial College in London. Why do you think that is?
Yeah, so I think this goes back to the lack of testing early in the epidemic. So early in the epidemic, we were only testing the sickest patients, the ones especially that were showing up to hospitals because they were sick enough to want to come to a hospital. And then we were counting the number of deaths among those people. So obviously, if you're only looking at the mortality rate in the sickest portion of the population, it's going to be higher. Right. Once we started more widespread testing and we're able to actually say that, in fact, probably about 80% of these cases are mild, maybe up to 20, 25% are even asymptomatic. Then once you divide that number of deaths by that much larger group of people who have mild disease, who are asymptomatic, you find that your mortality rate is actually much lower than you thought initially. And that's not uncommon. We see that with a lot of, infectious diseases where the mortality rate starts off high because we are only testing people who are very sick. And then once we expand testing, we see it come down. Also, as we get better at treating it, we can expect that the mortality rate will also come down. It's not a fixed number for any disease, and it can improve with even good supportive care. During the Ebola epidemic, long before we had a treatment that was effective, and in fact, we only discovered the first effective treatment for Ebola this past November on a study that I worked on in the Democratic Republic of Congo that found 2 antibody-based treatments to be very effective. Before that, we didn't have a treatment for Ebola, but we were able to reduce mortality significantly just with good supportive care by providing patients with fluids, with nutrition, in some cases with vitamins and antibiotics, and that was able to reduce their mortality from levels of 60, 65% down to 30, 35, 40%.
So we were obviously predicting, massive numbers, 550,000 deaths without any intervention in Britain, for instance. That's what the Imperial College report suggested. That was by Dr. Ferguson. We're not seeing numbers anywhere close to those predictions today. What I'm trying to get at is, did we overreact? Are the lockdowns an overreaction?
So that's a tough question. Most of those models that you saw that were predicting really high levels of cases and mortality, both in Europe and in North America, those were based on the concept that we did nothing. If we just let the virus spread through the population and we did absolutely nothing to stop it, those were the numbers we would have seen. Of course, nobody has done nothing. Every country has taken some action against this virus. And certainly the social distancing measures that have been put in place and the lockdowns, which are an extreme form of social distancing, they've absolutely slowed the ability of the virus to jump from person to person. And therefore, they've reduced the number of cases overall that we're seeing per day. And as a result of that, they've reduced the number of deaths that we're seeing per day. So, in many ways, yes, the lockdowns were effective in their primary goal of reducing the spread of disease and avoiding those, incredibly horrendous projections of really high numbers of hospitalizations and deaths, which would have, completely overrun our healthcare systems everywhere in the world. The downside of the lockdowns is that they have also, put millions and tens of millions of people onto unemployment rolls around the world. They've caused some people to go hungry, and in many cases, they've led to losses of economic activity that will take years, if not decades, to overcome. So the lockdowns are a blunt tool. They were effective in reducing the spread of the disease, but they also have really significant negative consequences. I think that what most leaders know and what most of the world understands is that these lockdowns will need to be transitioned into the standard 4 pillars that we've used to manage all sorts of emerging and non-emerging infectious diseases throughout history. And those 4 pillars are a much more subtle way of being able to manage the pandemic while still allowing your economies to operate.
So do you think social distancing is going to be something that we're going to have to learn to live with forever?
I think we will have to have some form of social distancing. Forever is a very long time, but certainly for some time to come. And possibly it will become a new factor in human interaction, because even once we control COVID, there will always be the possibility of another pandemic. In fact, the likelihood of another pandemic, and having in place certain social distancing measures will probably be effective in stemming the spread of that in the future. But what does that social distancing look like, right? It may be as simple as transitioning from handshakes to the other forms of greeting that some societies have. That by itself, may be effective. And social distancing doesn't have to mean that people are locked in their home 24/7 forever.
Now, lockdowns obviously have devastated societies all around the world, but coming out of lockdowns is also important. Lockdowns were clamped, as you said, just like a blunt tool. But how should we come out of it? Step by step, rung by rung, I assume.
Yeah, so I think the answer is that you replace the lockdowns with the 4 pillars of pandemic response. Even after you get the cases down to a very low level, because of the lockdowns, as soon as you lift those lockdowns, those cases are going to start going up again, unless you put into place simultaneously the 4 pillars. So number 1, community education. So you need to create certain social distancing guidelines that are going to be workable in a standard society. And there's not one answer to that. The World Health Organization can't give one answer to what that looks like. It has to be based on local cultural and economic considerations. What we learned in West Africa is if
Yeah.
we tried to go in and tell communities, you can't bury your dead, you can't, touch the sick, that was unworkable for them. And so we had to work with them and talk with them and figure out, okay, how can we adjust your cultural practices around burial, around caring for the ill in a way that prevents transmission of the disease? And communities were able to come up with really smart ideas for how to do that, which fit into their own cultural and sociologic background. And so we've got to be doing that around the world, figuring out how to make social distancing work within communities. And to do that, we've got to be talking to communities right now to figure out how to make that happen. Number 2 and 3, we have to have widespread testing and contact tracing. Testing, the test kits are limited. They are somewhat expensive. But in many countries, contact tracing is really just about hiring a lot of unemployed people and just teaching them how to be contact tracers. It's not the hardest job in the world, and it could, potentially put a lot of people to work at the same time as helping stop the spread of the disease and preventing the reemergence of the disease once the lockdowns are lifted. And then finally, you have to have your treatment in place. You have to make sure that your hospitals are prepared to start seeing more cases of the disease, because as soon as you lift the lockdowns, you will have more cases of the disease coming in. And healthcare workers just have to have the correct protection. They have to have the right training, and they have to have the right supplies to be able to treat these cases when they do come in.
Are you seeing an increase worldwide of mortality as a result of medical conditions other than COVID because of COVID?
Yeah, the data is just starting to come out. I've only seen the data in the United States, but it looks like in the last few weeks of March, first couple weeks of April, perhaps an equal number of people died of other diseases than COVID-19 because of the pandemic than COVID-19 itself. So roughly, we had about 8,000 excess deaths in the United States during that time period from COVID-19, and we had 8,000 more excess deaths than would have normally been expected from other diseases besides COVID-19. And so, we expect that to probably increase when we are able to see data from the rest of April. And I'm sure when other countries around the world start looking at their own data and start looking at the number of deaths that they've had since the pandemic started in their country, they will also see a lot of excess deaths. Some of those deaths may be people who had COVID-19 and just weren't diagnosed, but many of them will be deaths from heart disease, from diabetes, from other infectious diseases like malaria, et cetera, that just weren't able to be treated because the health system wasn't functioning or people were too scared to come in to the hospital as a result of the COVID-19 pandemic.
So how far away are we from a vaccine?
Yeah, that's a really, really good question. We are moving faster towards a vaccine than we ever have in history. The Ebola vaccine, which was, pretty incredible at the time in 2015, it went from what's called sort of the phase 1 trials when you first start testing it in humans to the final phase 3 trial in just 10 months. And that was a record at the time. And we are probably moving even faster now with COVID-19, moving vaccines from, really just a theoretical stage to phase 1 trials in humans, where you test it on just a few healthy people to see if it's safe, on to phase 2 trials, where you see if it works to develop immunity in people, and then to phase 3 trials, where you see if it actually protects people from disease. I would guess that we will probably have results from a vaccine within the year. Basically, by early 2021, we will have studies published that show that certain vaccines work. There's more than 85 being tested, and so I'm certain we'll have studies that show that some of them work. Now, the problem is that getting from that to vaccinating the entire human population takes time. So just discovering, it's not like the movie where you discover the vaccine and then all of a sudden you can vaccinate everyone right away. It's going to take time to produce enough of those vaccines to vaccinate everyone. And so, realistically, we're looking at, the end of 2021 at the earliest that everybody could be vaccinated. And that's if we do everything correctly.
How much worse is this going to get, or how much better will it get? Are we going to see, for instance, we've seen some nations suffer a lot more than others. We see a vast disparity between the numbers between nations. You see countries with relatively well-developed healthcare systems, like Italy, for instance, go through the doldrums, whereas it's not so bad in Germany. And then you have a complete anomaly in Sweden. So, sitting here in Sri Lanka and in, India and Myanmar and nations like this, we don't know whether, we're doing all right or if we have to brace for something that is yet to come. What are your thoughts?
Yeah, so I think that the countries that were hit first by the epidemic were the least prepared for it. And, frankly, that's a large part of, why the numbers and the case fatality rates were so high in those countries. Other countries, especially those in the global south, which are just starting to see the rise in cases, have time now to prepare and have done probably a better job of preparing in some ways than many countries in Europe and North America. So, the key aspects of it are, again, the public education, working to figure out how to get societies to practice social distancing and to practice measures that will decrease their likelihood of being infected, like hand hygiene, et cetera, and how to do this in a way that is culturally appropriate for them. Sweden, many people say is an anomaly. It's a country where, you didn't have to tell people too much what to do. They were all willing to just start social distancing on their own. You didn't have to have the heavy hand of government to force them to do it, because you just said, this is what you need to do from a public health standpoint, and they were all willing to do it. That may not be the case in other countries, but it probably is the case if you actually are able to take the time to explain to a community in words that they understand why this is important. And they can probably help you figure out how they can establish good hygiene and social distancing measures within their communities, given that information. And so countries that are able to, communicate that right now, countries that are able to start up testing and contact tracing for those individuals who are infected, and it's so much easier to do when the numbers are still low. When you only have a few dozen cases a day, it's much easier to test and contact trace those than when you have hundreds or thousands of cases a day. And so the earlier countries can start on this before the epidemic gets really large, the bigger the impact they're going to have.
So how important is random testing, as opposed to testing suspected cases that you find out of the contact tracing?
Yeah, I think random testing can be helpful from a research and from a modeling standpoint. It can help us understand what proportion of cases are asymptomatic in the population, and can help us understand, also just how good our current contact tracing system is. If we're catching a lot of people on random testing that weren't being caught through contact tracing, that we know that our contact tracing isn't working very well. But from a public health standpoint of simply getting the epidemic under control, random testing isn't necessary. What's necessary is testing of everyone who's symptomatic, and then really good contact tracing of those individuals' contacts. And we have new tools now that we never had before, in addition to sort of the standard contact tracing of, what we did in West Africa, which is we just asked everyone, who are all the people you've been in contact with? And then we went and found those people and talked to them. Now we have apps that can tell us where people, when people passed in contact for large amounts of time with other people. Those apps may be helpful in ensuring good contact tracing in certain countries. And so, we should definitely be putting these new tools to use as they become available. I do think it's likely that in most countries in the world, the true number of people who are infected is probably 5 to 10 times higher than the number of official cases that the country has, simply because they're not able to test all these people with mild symptoms or the people who are asymptomatic. But I don't think it's going to be 100 times higher or 1,000 times higher, And so therefore, I think it's unlikely that any country, with the exception of maybe like countries with really, places that had really bad epidemics, like New York City, for instance, outside of those places, I don't think it's likely that, anywhere in the world has more than 5% or, 10% of their population that's that's actually been exposed to the disease and developed antibodies to it. So if the question is kind of one around herd immunity, I don't think any country has that and can depend on that as a way to forestall the spread of the epidemic. I think the only way we're going to get to herd immunity is with a vaccine, honestly, and that's
why
going
do
to
you
take
say
until
that?
sometime next year.
Why do you say that?
Because I think that if we tried to get to herd immunity without a vaccine, i.e. by exposing the whole population to the disease, number one, that would take time, that would take many months, maybe even a year or two to do. Number two, we would see many, many hospitalizations and many, many deaths. I mean, even with a mortality rate of 1%, you take a country, I don't know, what the population of Sri Lanka, is it 100
about 22
million?
million. No, it's about 22 million. Yeah.
22 million. Okay. So, 1% of that, is 220,000 people. You can't have 220,000 of your citizens dying in order to achieve herd immunity. It's just not, the benefit is not worth the risk that you have there. Instead, you need to put in place the 4 pillars that can allow you to get to a point where you have a vaccine, have a certain number of people die, certainly a certain number of people will die, a certain number of people will be hospitalized, but be able to get to that point where you have a vaccine without having hundreds of thousands of people die and millions of people needing to be hospitalized, because obviously your system can't handle those numbers.
So I know this is kind of a morbid question, but are we seeing people who would probably die within maybe the next 2 or 3 years, dying in a month or two? Basically people above a certain age are far more susceptible to be a fatality of the disease than others are. So, is this what we're seeing in the numbers across the world? Older people dying in larger numbers in a shorter period of time.
Yeah, no, it's absolutely the case, and we've seen this in every country in every study on this disease, is that the people highest at risk for death are elderly people, and basically the older you get, the higher your risk for mortality. Other things that make people more at risk for death are other types of health conditions, especially heart disease, lung disease, diabetes. People who have those conditions are more at risk for death. Younger, healthier people are much less likely to die. And, in many ways, this will help the global south, where you have lower proportions of your population that are older, and you have lower proportions of your population with some of these chronic diseases like heart disease, lung disease, et cetera. And therefore, we can expect that mortality rates may be lower in many countries in the global south than in Europe and North America as a result of that. Of course, they may be also higher because of a lack of access to the definitive or the supportive types of medical care like oxygen and ventilators, et cetera. And those, it's really hard to know to what extent those two factors will balance each other out. But it is, certainly true that people who are older and people who have other medical conditions are more at risk for death.
So you absolutely don't believe that we should just let this kind of roll over and let nature take its course, that intervention is absolutely key to controlling this and ensuring that the numbers are kept low?
I mean, as a physician, I think it's hard for me to advocate letting millions of people around the world die unnecessarily.
Do you really think it's going to be millions? Do you really think it's going to be millions? If you just,
Again, if we wanted to get to herd immunity for the entire population of Earth, that's 7.5 billion people, then you are talking about 75 million people having to die to get there.
That's at a 1% mortality rate, but this is not showing a 1% mortality anywhere. It's a lot less.
Well, I don't actually know that that's true. I think the best studies that I've seen suggest a mortality rate of around somewhere between 0.5 and 1.5%, centering around 1%. So the best study I think actually done on this was on the Diamond Princess cruise ship, because every single person on that vessel, and so we
Right.
actually have the true denominator of how many people were actually ill, because everybody on the ship were tested, and we know exactly how many people died, and so we can get better numbers than we can in a general population anywhere else, where we don't exactly know how many people really had the disease and how many
So
people died
when
from
we're
it.
talking about the mortality rate, are we talking about 1% of affected people or 1% of a population?
It's 1% of infected people, but
Right.
if you get to herd immunity, then you're talking about 70-80% of the entire population being infected, and so then it's
Right.
1% of that. um, so if it were the only way, then perhaps some ethicists could debate
Sure.
whether it should be done, but it's not the only way.
Yeah.
We can vanquish this disease, or at least control it in a way that we can live with it,
Sure.
simply by instituting the 4 pillars that I've talked about. And that's easier said than done. In some places it will cost money, it will cost resources, it will cost time, but it can be done in a way that still allows our economies to function.
Do we have to expect a second and a third wave? And if so, when?
Second, third, fourth, fifth, sixth, eighth, ninth, 10th, there will be a constant up and down, and that will be different in every country. As you loosen restrictions, there will be an increase in cases. As you put into place better health education, better contact tracing, better testing and treatment, the numbers of cases will go down, the numbers of deaths will go down. As that starts to loosen again, the numbers of cases and deaths will go up. At some point, we'll have a vaccine, and that will largely control the disease. But we don't know if the vaccine will last forever, or if it will need to be re-given every year or so.
Yeah.
And
Yeah.
so, it very well may be that 30 years from now, we're all getting our COVID-19 vaccine every fall.
Just like
And
the flu shot.
just like the flu shot, and just like the flu
Yeah.
shot, some percentage of people won't do it. They won't think it's necessary. They'll have forgotten, and then they'll get infected, and then we'll have a spike of cases, just like we do with the
Yeah.
flu in certain seasons.
Love
So,
to hear about the work that you do with the Watson Institute and Project Hope. I know you work with many, many countries, particularly developing countries, and I'm going to talk to you about the potential of working potentially with Sri Lanka as well. But what have you been doing with Project Hope so far?
Project Hope is an international humanitarian organization that has been one of our partners for many years, and they approached us in February, back when the epidemic was really taking off in China and just starting to spread to some other countries in East Asia, long before it actually spread elsewhere in the world. And they approached us about the idea of developing a health worker training program specifically for health workers in low and middle income countries to prepare their health systems for COVID-19. So it was very prescient. It was the idea that eventually this disease will spread, and if we can get countries ready for it, then they don't have to see the high numbers of cases and fatalities as we did in China and other places.
Right.
And so we worked really hard and really fast. We had a team of about a dozen faculty members, and we built this 12-hour, 8-module remote training that we deliver over the Zoom platform.
Right.
This training covers all the different aspects of COVID-19 preparedness and response, from the public health side of how you properly do surveillance, infection prevention and control, both in the healthcare system and in the community, and communication, risk communication to communities, all the way to how you stabilize and resuscitate very ill patients, how you diagnose and manage the disease, and how you treat patients who are infected. So in addition to the modules that cover the basics, we also have a variety of videos and case exercises built into the training to help health workers really imagine how it's going to be in their system. And we set it up as a training of the trainers model. So that means that with our initial training, our faculty at Brown are training health leaders in each country, and then we give them all of the training materials, and then they can go and take that and train others in their country. So far, we have conducted this training in about 15 or 16 different countries around the world, from Indonesia and the Philippines to Kosovo and North Macedonia to Ethiopia, Nigeria, to Bangladesh, and many, many other countries. Even some countries, even part of the United States, we conducted a training in Puerto Rico for this as well. So far, we've trained about 700 or so health leaders, and they've gone on to train over 3,000 healthcare workers in their countries. So it's really had an incredible impact, and we're seeing that starting to spread even more and more as those secondary trainings are cascaded in different countries.
Dr. Levine, we're going to end this now, but I want you to, give us your final thoughts, something optimistic maybe. Are we going to be smiling in a couple of months?
I hope we can smile now. I mean, there's still a lot of wonderful things to look forward to in life, even in these difficult times. And for those of us who are lucky enough to have our own health and to have our family's health, we should really appreciate that, certainly. So when I was in West Africa at the very height of the Ebola epidemic, things looked horrific. The numbers were going up exponentially every single day. The projections were that up to 500,000 people could be infected in Liberia and Sierra Leone by January, which would have been, almost a tenth of the population. And people were really scared, and we were struggling to just build our first Ebola treatment centers to isolate and care for people. And the truck pulled up to deliver the gravel for our first Ebola treatment center that we were building. And on the truck was a sign that said, "No condition is permanent." And I took a quick picture of that sign because I was hoping it would be prescient. And it certainly was. We were able to end the Ebola epidemic in West Africa. It took us over a year and a half, almost 2 years to do it. But we were able to do it in the end. And that's going to be true of COVID-19 as well. Eventually, we will control this disease. We will get it to a point where it's no longer first and foremost in our minds, a threat to our psyche and a threat to our health and to our economies. We will get there. It's just going to take some time, and we just have to get through it.
Dr. Levine, you're the man about the world. You are a researcher. You do your work in the field, and I want to thank you for all that you do to try to make the world a better place, you and your team. I look forward to talking to you maybe in a couple of weeks again, if you can find the time for us, just to see where we are again, and pick your mind, because I think it's very, very important. I think pillar one, awareness, education, just knowing a little more and staying ahead of the learning curve, I think is very important. And these couple of minutes you spent with us has been extremely helpful. And we thank you for your time, and we wish you and everybody at Brown University a very safe couple of days. And let's all get to the other side of this, because, as you just said, no condition is permanent.
That's right. Thank you so much for having me. It's been a pleasure.
Absolute pleasure. Bye-bye.